Our main goal is not to count the number of people who have a particular disease, the number of sheep in a country, to go out and just identify the magnitude of problems. That's the first step, and it's a very important step, because that information has really armed us to work with people in the service sector and people who are involved in allocation of resources to prevent and treat these conditions. So by demonstrating their pervasive magnitude across the world, it's been a very important effort that has now, I think, come to fruition. So as epidemiologists, the first step is to identify the magnitude of conditions in the population. So that's why many of us were halted over the last 30 years, because we didn't have the tools to go out and knock on doors and ask people if they have particular conditions. We have been completely tied to the diagnostic classification system that was in vogue at the time. So for those of us who are doing studies over time, if they keep changing, if the number of symptoms changes, if the age of onset changes, if we eliminate a subgroup, such as Asperger's, then it completely changes our ability to follow people over time to look at patterns and trends. So as such, it's been very important for us to separate a bit, to look at the magnitude of these conditions without respect to adherence to the diagnostic criteria du jour. So what we're most interested in, the goal of our field, which really attracted me to it when I was first studying cardiovascular epidemiology, is we put together all of the different domains of risk to come up with risk profiles, to derive profiles with which we can predict onset of disorder, or we can predict persistence, course, and treatment outcome. Epidemiology originally focused mostly on the environmental characteristics. So in the 1960s and 70s, it was believed that the social causation theory of mental disorders, particularly psychoses and schizophrenia, the urban versus rural environment, the stress of encountering the types of problems we have in urban settings. And we know a lot about social class, we know a lot about poverty and so forth, so the broad contextual factors really were believed to be causal. Then we've had a big shift, and in the last decade, the focus has been almost exclusively on host characteristics for many conditions. Genes focus on individual genetic and biologic makeup. So a lot of the work has shifted to try to identify what the different brain circuits are that lead to the conditions that we study. We have neglected other host characteristics, things that come with people that may not be genetic, they may be ultimately environmentally induced factors that go with the person. So we look at gender, we can look at social class, and those really can be considered under the host. Now more recently, with agents, there's a lot of really interesting work going on showing us how viral infections, bacterial infections, accidents, injuries, lack of proper nutrition is also underlies a number of the mental disorders that we study. So we've learned a lot individually about how all these three domains of risk alone might lead to mental problems, mental disorders. But what we haven't done very well is put it all together so that we can look at the profiles, we can put them together, we can look, do they add up? Like Michael Rutter said in the original Isle White, when they looked at risk factors, they found an additive influence. And the number of risk factors you accumulated, it didn't matter which ones they were, that would lead to the subsequent development of a problem, impairment, or disability from a mental disorder. So I think at this point, we now really need to move to understanding how these domains influence each other and their mutual influence. And they appear to be quite different for different conditions that we study. So the one-size-fits-all etiologic models, it's very clear now that those really don't fit and aren't easily translated into prevention and intervention programs. The other major issue that we deal with as epidemiologists is that we try to go below. Actually, I can see them right here, so I don't have to. We can look at what's in the population beneath what we see in the clinics. And at least in the United States, this is becoming more and more divergent. It's very rare now for people with routine mood disorders, even people who are characterized as having severe bipolar disorder. Very rare for them now to get to specialty sectors in psychiatry. They are being treated in the general health sector. So there's even a greater divergence over time in identifying people with these conditions. Many show up in the prisons, in the juvenile justice system if we're talking about children. Others are identified in the schools, and then with limited resources to refer them for help. The schools try to do the best they can to help the children who are having difficulties. So the specialists, even child psychiatrists, of whom there are too few in our country, there's a real scarcity. People don't get to the experts who really are the best at putting together the profile of risk and understanding whether the child needs medications, do they need some kind of family behavioral programs, can they work with the context in which that child finds themselves to prevent further progression and diminution of the sequelae of the condition. In epidemiologic studies, population-based studies, which have now come to their maturity across the world, we now know a lot about what's down here. And we've looked at this now in many of the developing countries as well. It's no longer just European countries, the US and Australia, Canada, and so forth. We're now beginning to accumulate evidence from Africa, from the Middle East, even in the midst of all the turmoil, to try to get an understanding of the magnitude of these problems. And what's interesting is, although we might see different rates of conditions, the magnitude differs depending on what tools we use. What we see is the risk factors, patterns of comorbidity, which I'll be describing in a moment, they really seem to be identical. So that is what has given us some sense that we're really we have some clues about what are the risk factors, what are the sequelae, and are those universal across the world? And can we, in countries who have the wherewithal to institute prevention and early intervention programs, early identification, can we then take those tools and translate them to countries who are less fortunate in terms of research efforts and dollars? So let me talk about the magnitude of mental disorders, and I'll talk about the United States. So even though I said that the field of epidemiology in terms of descriptive epidemiology has really come to fruition, and people are working together across the world, the field of child psychiatric epidemiology is still very sparse. We don't have good measures, universal measures across the world, where we can begin to compile the information to estimate the magnitude of these problems across various countries, settings, ages, and patterns of conditions. So that most of the data we have are based on symptom checklists that people apply in the general population. So we know children who are disturbed or having problems or symptoms at a particular time. Most of those scales just collect how are you today, or the last week, or the last month. So now we've started to shift in the US, in Netherlands, many other countries have begun to collect data. New Zealand, Australia have also begun to follow children. We have begun to collect data that we can then match to adult criteria to begin to look at how the disorders begin. At what age do they begin? When do children express the full spectrum of these conditions? So in the United States, if you look at these rates, and these have been published, they've been published here and elsewhere, if we add all these up, we find that almost 50% of children in the US general population of children ages 13 to 18, adolescents, meet criteria at one point in their lifetime for one of the disorders that are defined by DSM-4. So they've had an episode of depression of at least a week. They have phobias, they have anxiety. These are part of the human condition. Fears, anxiety, depressed mood. Most of us have these conditions from time to time, and many of us will meet criteria at any given point in time. The important issue is, do they continue? Do they persist over time? Do they recur? And our criteria do not include recurrence as a criterion for a disorder. So what we did was start to look at impairment, severity, and recurrence to get a sense of, we know that these conditions are pervasive, but then the question becomes, how many of these children really are in trouble? How many of these children who are having these problems are going to begin to have problems that are going to keep recurring? It's going to impair their social, their physical, and their academic development. And the further they go off the path, the harder it is to intervene, even with early intervention. So depending on at the age at which they suffer from these problems, the longer the period, the lag period, between when they really start to have impairment, start to have severe manifestations, then the harder it is to get them back on track. So that's why we think it's very important, and that's why I think the work that you're doing here to work with early adolescence, early symptoms, early expression, and the phases of disorder is so important. This is particularly true in terms of prevention of substance abuse, where the earlier we help these kids with their problems, the less they're likely to go out and to go off the track and have difficulty with their lives. Now, this is a slide that shows the treatment patterns in the United States. You've all read about what they're calling Obamacare, affordable care. In the United States, we recently had a law enacted for parity for mental health, in that insurance companies can no longer deny the payment for mental health services. And there's some very specific, they're trying to develop evidence-based guidelines. But the problem in the child field is we really lack evidence-based guidelines for many of the childhood disorders. And that goes beyond psychiatry. So one of the issues has been, it's easy to say that we don't need to apply this or that treatment, behavioral treatment, cognitive treatment, medication treatment, if we don't have guidelines about how to put all this together and at what point to intervene. So one reason that this is important, if we can go out and we can show that only 50% of kids with a major disorder, and these kids meet criteria, only 50% ever get to a mental health professional. And we use this as a very broad identification of kids getting into mental health care. These figures include school-based treatments. They include social workers, educational intervention. Anything that is seen as a mental health contact is included here. So if we then start to talk about specialty care, it goes way down to about 10 to 15%. And in some countries, we do a very good job of putting together teams of experts, educators, social workers, nurses, psychiatric clinicians, medical doctors and physicians, putting people together to develop treatment programs, which is really what we need to aspire to. But in other countries, when your entry to treatment and your treatments are determined by whether they're reimbursed or not, that's when we start to lose people, because it's much quicker to give a young person who has a depressive episode an antidepressant and then see them maybe one time to see if they're doing better with no follow-up. So we never know what happens to those people. And that's why these models that I think you're doing very well in many countries are going to be so important for the future, because it's our burden to demonstrate that these are effective and that these help. Now, I wanted to move on to a shift from a disorder-based identification, which is what we do in epidemiology, and the recent disability ratings that just came out in Lancet in August that were developed, actually led by a team from Australia. Those are based on disability associated with disorders, not with persons. So we'll say disability from major depression, disability from anxiety, disability from substance abuse. But in truth, any of you who are clinicians, know that when we see somebody, it's very, very rare to have a person who only has one of these conditions. So what we did was to study this in the general population. Where we go out into the population, people are not necessarily seeking care. And it turns out that comorbid conditions are probably the chief reason that people get to mental health care. So if somebody has substance abuse and psychosis, they're more likely to get into some kind of setting than people who just have psychosis or just have substance abuse. With children, and I think this what gives me some optimism and hope, we find that about 60% of the children, 13 to 18, are only meeting criteria for one condition across the lifetime. So this suggests then that these children don't have complicated conditions. We may actually be able to intervene for these particular conditions before they develop the sequelae or the problems that are consequences of the condition. Now, the children who really need the mental health care will be this group up here. That's the kids who have 3 classes, and I'm sure the 70% didn't show. But about 20% of youth, and I think this has been demonstrated across the world, certainly some other countries where we've been working, Switzerland, Scandinavia, Germany, about 20% of the children with a mental disorder at any given time have severe mental disorders with at least 2 or 3 other conditions. So it's the kids who have multiple conditions that tend to need the most care. And those are the kids who, if we could then move beyond saying they have multiple conditions, classify, characterize the child, and then I think the biggest challenge is for us to understand what are the explanations for comorbidity. What makes a child with ADHD develop severe depression in early adult life? Is it a consequence of that child's inability to negotiate the education system? They can't get into the university, they can't attend to taking tests, they can't do well. Then is that why they develop depression? Many children with attention deficit disorder also have difficulty with physical functioning, clumsiness. Those kids aren't good at sports. A boy who's not good at sports in some societies doesn't do very well socially. So the consequences of these conditions, they can be disorders, they can be just consequences with life functioning. And I think that's where we have a lot of data now that if we put it together, we can start to develop models where we really see it is a consequence. If it's a consequence, it has a major implications for our interventions. Because those kids, we could go in there, we could help them to negotiate the system. We could help them to get through the education system, either by medication, by adapting their environment, by helping them with their family to cope and institute these well-established behavioral treatments. Okay. Okay, now the other area completely neglected is medical conditions. So there is a huge gap between medical disorders and mental problems. So we've been now looking at mental symptoms and problems and their relationship to different medical or physical conditions. And it turns out that in adults, this is adults, about 25% of people have both, and only 8% of adults, and the older you get, the more you develop other diseases, have mental disorders alone. So we really fail to consider medical comorbidity in children and in adults when we're developing treatments and prevention. It turns out that in children with asthma, allergies, head injuries, and these kinds of conditions, which are very, very common, that these children respond differently to treatment. Children with attention deficit disorder, about 40 to 45% of them have enuresis that lasts to age 8. They have developmental lags. So children with conduct disorder and ADHD tend to have behavioral problems, learning disabilities that start already in 1st and 2nd grade. So they're not children with ADHD, they're children who have developmental problems across the lifespan that we really need to turn to the education system to help these kids. On the other hand, children with mood disorders, we're now showing that there's immunologic conditions that lead to depression. And hence, if we could treat that, prevent that, we could then prevent the sequelae of depression. Okay? point I wanted to make, okay. The last point I wanted to make is we are adhering to DSM criteria. You have or you do not have a disorder. What we've been trying to do, and this is by my learning tutelage from my mentor, Professor Jules Angst in Switzerland, where he says that these conditions all exist as a spectrum. That they exist, some people have symptoms. We've all had symptoms of anxiety, depression. Now we're learning more that the children do have delusions, they might have hallucinations. It doesn't mean that they have a disease. These are symptoms that are common, some more common than others. So what we're trying to do is characterize youth in the general population by dimension. So I just wanted, in my last slide or two, I wanted to show you that if you look at depression, the green shows the kids who meet full criteria. But look what you have under there. You have a lot of kids who just say, I have symptoms, and they've come back. The turquoise is kids who have depressive symptoms, and they have some impairment, but they don't meet full criteria. So if I'm going to do prevention, and I'll go on to my last slide. If I'm going to do prevention, this is the mental health intervention spectrum that we put together in the 1990s as part of a work group for the IAYMH on where we agreed about the terminology and when we actually do our interventions. So here in the green below this line are prevention efforts, and then we have this very blurred transition to case identification, which would be the early identification work that you're doing, and then moving on to cases. And these are the people who are seen as cases who are identified as patients. But it's this group who have these symptoms, if we look at dimensions, and we look at the underlying core features of these conditions. We put that together with the child rather than the disorder. So we don't do prevention, interventions for depression, for anxiety, for schizophrenia, for bipolar disorder. What we need to do is have profiles of the underlying core features of these conditions, including medical conditions, including educational attainment challenges. Put those pictures together, and only then are we going to be able to identify the timing of when we should intervene and how. And for some of these interventions, they're quite possible early in development, in grade school age, even before that. Others, we really have to wait until they've started to develop a little bit more fulminantly, such as social anxiety, bipolar disorder, and we start to see the episodes of activation, that we can intervene and start to prevent the sequelae of these very serious, life-threatening, pervasive conditions in the population. Thank you.